Okay, so we're doing home care today, not pediatrics necessarily. And what is it with this thing? F5, I have to remember that. Okay. Okay, so care in the home, whether it's palliative care or hospice care, it can be in the patient's own home, the relative's home, children's home. It can also be in a nursing home. So we have contracts with nursing homes to give hospice care, to deliver hospice care in nursing homes, and it's considered home care. Some organizations will go as far as going to homeless shelters, group homes we've been involved with, hostels, and even prisons. Did you have hospice? Not really. Okay. The models of care and the terminology vary with where one's location is and the health system that's there, and mainly characterized by symptom management and supportive caregivers. In the 1970s, the 1980s, the decision whether to discharge a patient home was often based on the patient's or the family's preference. We didn't have the push to shorten length of stay the way we do today. And sometime at the 1990s, when managed care got its hooks in the system, long hospital stays were replaced by early discharges, a shift of the care to the home with diminished patient and family choices. So we started, instead of keeping patients in the hospital for 10 days for IV antibiotics, we give them for 3 days and then give that care in the home. And that was just really something that happened about 15, 20 years ago. So home care staff and the families now manage pretty complex medical care at home. Ventilators, even in patients who are not imminently dying. And so the question is, how far will that go? Will we be delivering some degree of critical care in the home in the future? We say that home care has at least the potential for improving physical and psychological comfort, and certainly in patients who are approaching end of life, it may promote the healing of relationships. And the family can share in their transition from life to death. So when you look at home care, you need to ask yourself, how do we give successful care in the home? We have to consider what the needs of the caregiver are. We have to make sure there is a caregiver. And, some patients, as you may know, sign up for hospice thinking that they will provide all caregiver needs, and you really can't do care in the home unless you have a designated primary caregiver or caregivers. We want to palliate suffering. Pain, symptom management, spiritual and emotional suffering need to be addressed. We want to be prepared in some way for emergencies. So we're going to anticipate the urgent and emergent conditions that may arise and have either medications or a plan for what happens when a patient has a fever, airway obstruction, can't walk suddenly, etc. And then, of course, there's essential equipment that one needs. We measure the outcome of home care and evaluate it by the effects on the family members following the death of the patient. Positive experience with home care result in positive bereavement and adaptation by family members after the death. And we'll go through some of the literature that there is about this. So the question is, we always think that patients will be more comfortable at home. And does the literature support that? What are the statistics for symptom relief in the hospital versus home? And then what are the problems and needs of end-of-life caregivers? And finally, what makes palliative or hospice home care successful? So we know that regardless of where you live, most patients don't achieve their wish to die at home. In the U.S., there's 2.5 million deaths annually, and 75% of it occurs in an institution. 61% of that number occurs in hospitals and 17% in nursing facilities. And that number has remained constant or even increased since this study was done. What percentage of patients who wish to die at home really do so? In the UK, 55% of cancer patients want to die at home, and only 23% do. And whether you die at home depends on your age group. So younger age groups, age 16 to 24, 61% of them can actually die at home. Whereas the older age group, the geriatric population, only 49% comparatively die at home. In Italy, and this was a study done in a community palliative care service, 75% of their patients managed to die at home. In Sweden, even a lower number. And it seems that in Western Europe and the US, despite the awareness of palliative care services, the rate of home death seems to be steadily, slowly decreasing. So, I'm sure it may be out there, but I didn't see it when I reviewed this. What determines place of death, obviously it varies from country to country. The nearest hospital is 500 miles, but how do you get those statistics? In the UK, people who did die at home showed the following characteristics. They expressed their preference to do so. They were aware of the imminence of death, and they had had a relationship or had lived with the caretaker for a while prior to death. And it tended to be manageable in patients who had solid tumors. Patients who die in the hospital tend to be patients who have non-solid tumors and more than one illness. And that's from 2006 in Britain. Home death also depends on the role and the influence of the primary MD, called the GP in the UK. It also depends on the relatives' conception of where death should occur. And the availability of medications, equipment, handling of emergencies. And the biggest problem and precipitator of transfer to the hospital in the last few months of life, at least in my experience in hospice, has been uncontrolled symptom comes up. Some piece of equipment is needed and it's not in the house. Generating an admission to the hospital. So patients who die at home tend to be, there's a higher percentage of married people. They're less depressed than anxious, and they tend to be well supported. And that's an older study.
Is there a gender difference there?
I didn't notice.
I'll find that out.
Yeah,
Because
yeah.
my suspicion is it's more men who are dying. No, really, because women are,
I could see that. I could see that.
Yeah, so I'll try to find that out.
I would imagine it depends on age, because when you're talking about a couple who's in their 80s or 90s, now the primary caregiver may have a lot of medical illness themselves. So, okay. So deaths at home are decreasing, at least in the UK. In 1994, 27% of patients died at home, and in 2003, 22%. Even if there is a community palliative care service, and the palliative care service is considered to be of high standard. Specialist palliative care advice and if specialist palliative care is available around the clock. So at least there, when the studies they looked at, when those things were in place, it still didn't decrease the number of hospitalizations or institutionalized death. Okay, so we always think that patients are more comfortable at home. And this was an interesting thing to learn in my years in home care. And that's, to me, not always the case. Sometimes a patient does better in the hospital. So just wanted to address a few studies that looked at this issue. In Journal Pain and Symptom Management, 2003, there was a prospective study of 60 unresponsive dying patients. And the relatives and the nurses both evaluated the patient for discomfort, a set of behaviors, and reasons suspected for patient discomfort. Were asked the reasons they suspected the patient was uncomfortable. Okay. So the relatives reported more observed behaviors, grimacing, flexion, posturing, and associated pain as the reason for discomfort more frequently than did the RNs. So what does this mean? It means that relatives are more in tune to patient behaviors, and I guess variation from what's normal. And so whether or not those behaviors are really associated with more pain, we don't know.